I think we had really an interesting overview of all the approved and non-approved and development drugs. There are 2 or 3 questions, maybe one that is general, maybe for both the DLBCL and the CLL group, but let's get the answers. I think in the DLBCL talk, you may not have touched upon the allogenic transplant possibilities. Obviously, this man was rather old and may have been comorbidities, but what do you think is the role of allogenic transplant right now in the DLBCL field?
I think if you look at it, if you have a choice between CAR T cells and allogeneic stem cell transplant, I think the CAR T cell treatment would be the winner because of lower transplant-related mortality, less long-term toxicity. But if the patient relapses after CAR T and the patient is young and has a suitable donor, I think you could consider an allogeneic transplant. But yeah, if you look at the results in DLBCL, the transplant-related mortality is quite high, and the results are not that good. So,
Kieron?
I mean, I think in this particular patient, if you think about a long-term curative strategy, I think that most of us conventionally would think that the only one is some kind of allogeneic transplant. But I think the exciting thing is that a lot of the novel agents we discussed and a lot of the trials that are in development are reporting really good results in this patient population. And the question is, I mean, can that be equated with cure? Can some of these agents cause long-term remissions in a subset of patients? So,
I think in the CLL field, the question of allogenic has been still pertinent for some patients, as I understood both your talks, right?
Yeah, we're always discussing the allogeneic transplantation, but during the last 10 years, I would say we didn't transplant anybody. So because of the age, because of the novel agents, and it's always difficult. And we have to remember it's the only curative therapy we have for CLL, but there is 30% relapse in all the series. There is this 30-40% chronic graft-versus-host disease in a very old population. So it's a good choice, but you have to think. We just did allogeneic stem cell transplantation for Richter transformation nowadays, not for CLL. There is always a new therapy, fortunately.
So we have another. Yeah, sorry, Astrid.
No, with the introduction of new drugs, it's very difficult to actually encourage a patient to go into allogeneic transplantation, except for that small group of patients who have Richter transformation, in which we don't have any other available options.
Actually, touching upon the Richter transformation, what's your opinion, all of you, regarding the current standard of care, this different complication, which bring us from CLL to diffuse large B? Astrid, what's your point?
Well, I think this is a big unmet medical need, especially in patients who are receiving venetoclax, like this case for CLL, and turn out to have a Richter transformation. I think we would consider chemotherapy reinduction and try to take this patient to allotransplantation. We don't have any other options, but we know there have been some publications using venetoclax and chemotherapy, but in this case, for example, the patient has already received the therapy. So the best option would be to give more chemotherapy as a reinduction and try to offer this patient allotransplantation.
So what would be your regimen of choice for salvage in a Richter's patient? Which chemotherapy regimen?
Yeah, yes, Astrid.
No, go on.
Now, one of the problems with Richter is that around 70% of the cases are p53 mutated. So in general, they are chemo resistant. So we are always giving R-CHOP unsuccessfully. So we have some cases that I think immunotherapy has a role here. There are some nice reports combining nivolumab plus ibrutinib, or so we have, for instance, good experience with a bispecific combined with PD-1 inhibitor, and the patient attaining a response and going to allotransplant. So I think the field should move to non-chemo combinations, because by definition, most of the Richters are clonal related Richters, because the unrelated are another history, but clonal related are usually chemo-resistant.
Kieron, any insight regarding this question?
I think this population of patients, they have a significantly worse outcome. And, I agree with Astrid. I think that I think it may be a subset of aggressive lymphomas where allotransplant may be particularly effective. But I think the numbers of patients with this are very low, and there's not a lot of published experience. But allo works pretty well in follicular and in mantle cell lymphoma, maybe a bit better than diffuse large B cell lymphoma. So, but I think the new drugs are exciting to study and develop in this subset as well.
So to my friend Olivier Hermine, who was requesting this question, I think, Olivier, we don't have a very unanimous answer here, but thank you for stepping in. I think we have one question, Marie-José, which is a little bit specific to CAR-T, and Kieron may have some opinion on others too. Is this, in the patients that relapsed after CAR-T, do you try to monitor the CAR-T persistence? Is that giving you some indications regarding future intervention in this patient?
Yeah, so currently I must say we do this indirectly by looking at B-cell depletion, which as a sort of secondary measure. But yeah, it's not ideal. So I think it's interesting, but we don't really know what to do with it. So I think in DLBCL, if the patient is in a metabolic CR, and still after 6 months or 9 months, then it's not such a problem if they lose persistence of the CAR T cells. So you can have the B cells coming back, but the patient's remaining in a remission. So I wouldn't, it wouldn't have any consequences in that sense. But in the, if the patient has a relapse, you might think about, using a checkpoint inhibitor or lenalidomide to stimulate the immune response, or radiation therapy. There's several options by which you could sort of stimulate the immune response.
Yes, I think it's clear that unfortunately we don't have in many places the ability to measure the CAR-T, and the B cell is really indirect because it doesn't give us any insight regarding the functionality of CAR-T.
No.
Kieron, any precision on this topic?
No, I don't think so. I think it's becoming an interesting field in terms of people who have had CAR T cells and then get subsequent therapies. What the impact of the previous CAR T cell is going to be, and I think we're learning more and more about that, and especially with novel agents. So I think that's very interesting in terms of subsequent responses that might be influenced by the previous CAR T cell, although somebody has had relapsed refractory disease on that.
Yes, I think the ability to assess CAR-T may help us to go to immune-based interventions, such as you said, BTK inhibitor, lenalidomide plus rituximab, lenalidomide plus Tafa, if the disease is still CD19 positive, so there's other options. There is a small question, which I think is important, is when these new drugs and clinical trials are not present and the patient with DLBCL relapse after DHAP and autologous stem cell transplant, what are the options? I was thinking myself about VP16 containing regimens, which can be of use. Any other insights from your side when new agents or CAR-T and trials are not available? I think sometimes it's difficult cases.
In our country, as said before, we have very few clinical trials recruiting patients for. In my clinical practice, in this patient with diffuse large B-cell lymphoma, my best option would be in polatuzumab and Arbenda when it's available. We had it as a compassionate use, and it will be soon available, sooner than CAR T cells.
I mean, I think in this patient population, we're always wanting to cure somebody, even if they have relapsed after anti-CD19 CAR T cells, because they have large cell lymphoma. And unfortunately, a lot of the targeted agents that have been, I mean, this patient had non-GCB, but there is a good response rate, but it's just not sustained. So the trials are exciting because we're seeing sustained responses, but it's a problem if they're not available to patients. I really don't know what you can do in terms of thinking about a curative strategy. So it's a real area of unmet need. So hopefully we will accelerate sort of movement and approval of these effective agents that would be very helpful for patients.
So thank you all. I think we unfortunately have to conclude here. I think we had seen that there were many options being developed and maybe promising options. At the same time, they remain unmet need. I think I would really like to thank the organizer for having allowed us the SH to bring to the field. I really like also to thank the 4 speakers, and also thanks to both BMS and Insight, who have provided grant to support this activity. And please follow up this symposium on the Lymphoma Hub platform. Just click on the Lymphoma Hub in your website, and I'm sure you'll also find some other information regarding the development of agents, approval, and also intervention of most of our faculties and other participants to the Hub. Thank you for coming today. Stay online. There are very interesting sessions behind this one, and have a good evening in Europe and a good day everywhere else. Goodbye, and thank you again.